and other myeloproliferative neoplasms, stem cell transplant, and cell therapy. Dr. Kripa George is an associate professor in Medicine Unit 1, CMC Vellore. She has experience working in areas of need and has served as a consultant physician in Uganda at the Church of Uganda Kisizi Hospital and has contributed pictures to a published book on butterflies in the Indian subcontinent. Her areas of interest include toxicology, medical education, improving systems of care, and nature photography and music. Our speaker for today is Dr. Biju George. Sir is a professor in the Department of Hematology at CMC Vellore and has developed a pioneering conditioning protocol for aplastic anemia that is now a national standard and has led successful phase 2 trial studies on post-transplant cyclophosphamide to prevent graft versus host disease. He has established protocols for transplantation in Fanconi's anemia and initiated a DBT-funded study on aplastic anemia biology in India. Sir has launched and led the successful haploidentical transplant program at CMC Vellore, completing over 200 transplants. His areas of interest include aplastic anemia, Fanconi's anemia, myelodysplastic syndromes, post-transplant infections, and alternate donor transplants. His topic today is the updates in hematology.
Thank you so much. So I was given the topics of updates in ITP, medical diagnostics, and AI in hematology. And these by itself are very vast topics. So I'll just give you snippets out of each of them. Moving forward. Sorry, the slides are not moving forward. Okay. The first I'll talk about is ITP. So all of you know it's an autoimmune disorder characterized by recurrent bleeding, presence of antibodies against platelets, and then the destruction by the reticuloendothelial system. You have two different types. One is the acute ITP, commonly seen in children, which is usually self-limited. They usually present after a viral prodrome with bleeding and petechia and usually resolve in week. But the second form, which is more common in adults, is the chronic ITP, and they present with recurrent episodes of bleeding and with a relapsing course, and it is probably associated in a number of patients with other autoimmune disorders. Now, when we initially studied ITP earlier, in probably about 20 years back, the pathogenesis was that there were platelet or antibodies, which were autoantibodies. They sort of coated the platelets. They were recognized by the FC receptors on the spleen, engulfed and destroyed, and that led to the immune thrombocytopenia. So what we did in terms of treatment was to try and see how we can reduce the antibodies. So we used IVIG, anti-D, or corticosteroids as first line. If they failed, you had other immunosuppressions like azathioprine, dapsone, cyclophosphamide, or the third thing was to remove where the platelets were getting destroyed, so you did a splenectomy. But most of these treatments were associated with responses in about 50 to 60%, but then about 30 to 40% would relapse back. So people started to see, are there other things that can be done in terms of treating? So the first thing they focused was on the antibodies. Now these antibodies are generally formed by B cells. And so people started looking, can you do B cell depletion using rituximab to try and treat ITP? So initially the studies came out looking at weekly rituximab, and when they studied, roughly about 50% had a response. And if you look at the responses right at the bottom in C, is a patient who has a steady response with the platelets going up, but some of them show initial response and then a drop. And the important thing was that if you achieved a complete response, which meant a platelet count more than 150,000, you actually would do well long term. But those which achieved a partial response, that is 50 to 150, many of them would actually relapse back, which meant what it was not a long-term sustainable solution. So people started looking more to see what is the pathophysiology. And one of the things that they understood was that the autoantibodies actually can act on the megakaryocytes in the marrow and cause impaired megakaryocytic maturation and reduced platelet formation. So that became a target to see whether you could develop drugs that can act on that area. And what studies showed was that serum thrombopoietin levels in patients with ITP, and that's the one in the center. So you had low platelet count, you had low thrombopoietin level. which was different from healthy donors, where with the normal platelet count, they had low thrombopoietin level. So, can you use drugs to try and stimulate thrombopoietin production, which should actually help in improving platelet counts? And so there were two drugs that were discovered. One was L-Trombopag, which is in the center, which works on the trans membrane domain of the receptor, and then romiplostin, which acts on the extra membrane receptor. So there were two studies published in NEJM. One was with looking at L-Trombopag with about 118 patients at different doses, and essentially looking at getting a platelet count more than 50,000. So in about 80% had a response with the 75 milligrams, 70% with the 50 milligrams, no major problems, and it was very quick. So you got your responses by about day 15, which was very good. The second was romiplostim. Now, romiplostim is not an oral drug, it's an injection given once a week. So, this was a randomized trial comparing romiplostim with standard of care and looking at treatment failure, and responses were again 70%. Because of that, FDA actually approved both the drugs for the treatment of ITP. And so, in the last guidelines that was put up in about 2019, you had a variety of drugs that you could use depending upon what the patient's feeling was. So if the patient didn't want surgery, you had rituximab, you had the TPO agonist. If you were happy with surgery because it's a long-term solution, then they went ahead with splenectomy. Otherwise, if you didn't want long-term medication, you use rituximab. But there were still problems with the TPO agonists. And one of the problems was that nobody had defined how long do you need to take it. So they would give it and then go down to the lowest dose that would maintain the platelet count, but nobody looked at stopping it. Then the worry was that there was rebound thrombocytopenia when you stopped it quickly. You had hepatotoxicity associated with both the drugs. Now, the TPO receptor is not just present on platelets, it's present on stem cells, it's present on myeloid progenitors. And so the worry was that will it promote bone marrow fibrosis when you use long term? And of course, there was anti TPO antibodies. So then subsequently, the study came out looking at a new molecule which is called avatrombopag without much hepatotoxicity. This was a randomized double-blind controlled trial looking at placebo versus avatrombopag with an extension study. And they studied about 100 patients were taken, 49 studied, and essentially they showed that platelet response was very good. And so it was FDA approved in 2018. Avatrombopag is not available in India. Romiplostim and Eltrombopag is. They were very costly, but over the last 3 to 4 years, the generics have come in, which have actually reduced the cost, and that has become the standard of care. But whatever we did, it is 60-70% chances. So people are still looking at more inhibition, looking at more drug targets. So they are looking at BTK inhibitors at the macrophage level, complement inhibition. And so there's a lot of trials that are still going on in terms of whether newer drugs can be formed in the management of uh, immune thrombocytopenia. The second is in terms of molecular and cellular diagnostics. And I would say that is probably the area where the maximum progress has occurred in the field of hematology. And I think there are four major areas where this has happened. One is next generation sequencing, then in terms of transcriptomics, gene mutation analysis, and flow cytometry. And these are the four areas where the maximum advances have probably occurred. Next generation sequencing, I think, or sequencing has revolutionized the way we diagnose, prognosticate, and treat hematological disorders, whether we look at malignancies or non-malignant or benign disorders. Now, either you can do a whole genome sequencing or you can do an exome sequencing. What we do more in clinical practice is a targeted sequencing, because now we have targeted panels that are available for a number of diseases. And these are some of the targeted panels. So what you have on top is a targeted panel for acute myeloid leukemia. What you have below is for lymphoid malignancies. What you have on the right side is a bone marrow failure panel for bone marrow failures. And here is a panel for hereditary hemolytic anemias. And this is the kind of panel. So we have almost a 80-100 gene panel for bone marrow failures, which we have in the Department of Hematology, and targeted myeloid panel. Now, how do these help us? One, difficult cases you can actually diagnose. But I think more importantly, where this has helped us is in prognostication and planning treatment. So, how do we do that? So, acute myeloid leukemia has been there for a long time. We've always thought about it being a disease which was homogeneous. Now we realize it is not, and you would actually treat it with chemotherapy. So this is a 40-year-old who was diagnosed to have AML based upon a bone marrow aspirate and biopsy. About 20, 30 years back, we would have just straight away gone ahead with chemotherapy, decided upon response, whether this patient needed to go for a transplant or not. If this patient showed a very good response with the initial chemotherapy, you would have just continued chemotherapy. About 20, 25 years back, cytogenetics came in, which helped started looking at patients and saying, are these good risk cytogenetics, intermediate risk cytogenetics, or poor cytogenetics? And that sort of helped clarify who would go upfront for transplant, who would not. So this patient had a normal karyotype, which essentially meant that he had an intermediate risk, and so you could continue chemotherapy. And that is where next generation sequencing is coming, because now with next generation sequencing, we have started identifying mutations which still can affect the outcomes of chemotherapy. And what we did find in this patient is a FLT3 mutation. Now, how does this help us? There is clear data in literature to suggest that if you had a patient with the FLT3 mutation, they did very poorly with chemotherapy alone. So the overall outcomes, if we look here, is about 15% right at the bottom if you had a high level of mutation, and 28 to 30% if you had low level mutation. And this is true whether you did it at diagnosis or whether you identified it at the time of relapse. So what can we do about it? Now, there are 4 drugs available in the market which are called as FLT3 inhibitors. So, along with the chemotherapy, you can add on targeted therapy to actually treat the disease. Sorafenib, midostaurin are 2 drugs which are already available here. The last one, gilteritinib, is come in. Quizartinib is still not in. But clearly, they have shown that if you added that to the chemotherapy, and this is, if you look at the plot below, Kaplan-Meier, there's definitely an advantage of midostaurin. And importantly, even in patients who go for a transplant, if you use midostaurin maintenance, the outcomes of transplant were superior as compared to just doing a standard transplant alone. So using next generation sequencing to just diagnose this mutation has actually got an added benefit in terms of prognostication, deciding in advance what you want to do for the patient and how do you treat the patient down the line. I'm sure all of you have heard the story of chronic myeloid leukemia. Imatinib was the poster boy when that was the first targeted therapy for CML. That was before that, it was all transplant. But once we got a targeted therapy, that was what was used. The big problem with imatinib or any of the other TKIs was that you had to take it lifelong. So if you had somebody who was 30-year-old and you told him you have to take a medicine lifelong, down the line, always there are compliance issues and people wouldn't take it. So the question was, what could we do? So in patients with CML, we are monitoring them in terms of looking at their blood counts, but also looking at the real-time PCR to see whether the transcripts, which are the BCR-ABL transcripts, have come down to close to 0. And that is what is meant by deep molecular remission. So investigators have started to look at using this deep molecular remission, can you actually stop the drug? And so there was a study in France called as the STIM study to see whether patients who were in deep molecular remission for 3 years with imatinib, they could actually stop the drug and see what happened. And what they actually found was that roughly about 40%. So what they did was they stopped the drug, monitored by RQ-PCR. If somebody with RQ-PCR went up, restarted the imatinib, but about 40% actually did not require restarting of the medicine at all. And the long follow-up is up to 5 years after stopping imatinib. So which meant that it is a chronic disease, but it's a disease where the drug could actually be stopped. Transcriptomics is something which has come up in a big way because now we are looking to see whether the gene mutation signatures of a patient at diagnosis at relapse or those who have refractory disease are different. Now, why do we need to do that? Because if we find that there is a difference in the kind of gene mutation signature between these, then you can look and see what are the genes that are upregulated, what are the genes that are downregulated, and essentially see whether you can get targeted therapy. We have not reached that stage so far, but there is clear transcriptomic data to suggest that in a patient who's relapsed versus a new thing, with the newly diagnosed AML, you will have certain differences in the kinds of genes that are upregulated and downregulated. This transcriptomic or gene profiling has also looked at lymphomas. Now, about 15 years back, we had a diffuse large B-cell lymphoma. The treatment was for everybody rituximab with CHOP regimen. Now, with gene profiling, we have shown that the types of lymphomas are actually different. So you have what is called as a primary mediastinal B-cell lymphoma, and that the treatment is not R-CHOP. There's actually a different regimen called as R-dose-adjusted EPOCH, which actually works much better. They also showed that between the GCB and the ABC type of DLBCL, one is good, one is bad. So whether you give R-CHOP, one will show 70% response, one will show only 30% response. Now we still haven't, there are multiple trials that have happened looking at what can be done for the ABC subtype, but we still not got the answer. But this gene expression profiling has actually shown that lymphomas or DLBCLs are not uniform and you have unique signatures. In terms of treatment of leukemia, what is very important is minimal residual disease, or what we call as measurable residual disease. So when we give chemotherapy, we do a marrow. We look at the marrow, we say marrow is clear, which means there are less than 5% blasts in the marrow. It also means that roughly about 1 million leukemic cells are still there inside your body. And those are the ones which have to be killed subsequently with further chemotherapy or with the transplant. So if you look here at the middle one, so here is a patient who had hematological some response but relapse. The middle one is the one which is MRD positive, but hematologically is normal, but these are the people who are likely to relapse. And if you are MRD negative, these are the people who are likely to do well in the long term. So MRD has become a very important tool for us in terms of deciding, does this patient upfront need to go for transplant immediately after chemotherapy? Are they doing well on chemotherapy, or can we predict relapse for them because they do not do well? And there are two ways of looking at MRD. One is doing flow cytometry based assay, which is called as the multiparametric flow cytometry, or using qPCR. This is some data from our own flow cytometry. This is looking at B cells. So this is the normal B cell profile. And then if you look at these red cells, these are the ones which show you that there are blasts which expressing aberrant B cell antigens, which are suggestive of residual disease. Now, this is a normal T cell plot for a patient with T cell ALL. And if you look here, the red spots which you see are actually residual disease. Similar is there even for myeloid AML, and this shows the normal myeloid components, and this shows residual disease. So using flow cytometry, it helps us in terms of deciding, does the patient need further chemotherapy before we take up for a transplant? Is the patient that is at a higher risk for transplant? We have also in the lab used certain measures to try and reduce the cost of detection. So we have a novel RTP real-time PCR assay to detect beta thalassemia. We know that beta thalassemia in the children is a big problem, and we have roughly about 10,000 births with beta thalassemia every year in India. So we are able to detect about 13 common mutations in patients who come in for diagnosis, and it costs only 800. If you look at the large tests which are available, it costs about 2 to 3,000 per sample, and this is a low cost sample that is available. Sometimes we use this to prognosticate and decide treatment. So we had a 10-year-old child with pancytopenia. The bone marrow was consistent with aplastic anemia. There were no morphological abnormalities, had two children who were HLA identical. So obviously, a matched sibling donor transplant is the best thing that you can do for this patient. But because of a child, we always need to rule out Fanconi anemia. We did a stress cytogenetics. It was equivocal. It was not clearly negative. It was not positive clearly. So what do we do there? We go to either doing a Western blot analysis or doing a next generation sequencing. So when we did the next generation sequencing, we actually found that this child had Fanconi anemia. Now, because this child has Fanconi anemia and this is a genetic disorder, the most important thing now is to test the donor. So we actually, out of the two donors, one of the donor who's morphologically normal and has normal blood counts has also Fanconi anemia. So we cannot use that donor as a donor for transplant. Luckily, the other donor was normal and we could use him for the transplant. But it just doesn't stop there. Fanconi anemia is a DNA repair mechanism problem, which means that when you're transplanting, we have to reduce the conditioning drugs by almost 80%. Otherwise, they will get severe toxicity of all the drugs and die. So when we do this next generation sequencing, it helps us in terms of diagnosis. It helps us in terms of trying to find out a potential donor, but it also helps finally in terms of how we transplant the patient. And in the lab, this is which we actually have a full sequencing of how we can diagnose Fanconi anemia. Now, other than Fanconi, there is a lot of other disorders. Remember, India is one of the hotspots for genetic diseases because of two things. One is consanguineous marriages, and two is a lot of marriages within the community. So we had a problem where our adult patients with aplastic anemia did well with immunosuppressive therapy, but our children did not. And we were not sure why the children in the West, the response to immunosuppressive therapy in children were almost 80-90%, but we were getting 30% and 40%, while our adults were getting 60-70%. So the question was, in India, why are we getting this differential? So one of the things was, are we missing out on non-Fanconi genetic problems which we are not finding? So we actually screen. So we have about 3,000 patients with aplastic anemia in our database, out of which about 10% are Fanconi. And for a certain number, we decided to do next generation sequencing to look at children and young adults to see whether we can actually pick up inherited bone marrow failure syndromes that were being missed. And we actually found pathogenic variants. We did about 407 patients, and in about 12%, we actually found genetic mutations, which meant that they are no longer idiopathic immune aplastic anemia. They actually inherited aplastic anemia. And so trying to use immunosuppressive therapy in these patients will not work at all. The other thing which we also did was to look at something called as telomere length. Now, these telomeres are present at the end of chromosomes, and with each division, they slowly reduce. Finally, they die. That is the normal process of aging. There was data to suggest that the telomere length is shorter in aplastic anemia as compared to the normal population. So we actually had a DBT study where we looked at about 800 controls and about 650 patients with aplastic anemia. This was done by one of our postdocs in Eunice's lab. And we showed that actually about 60% of aplastic anemia patients had short telomeres. Now, that was the first step of showing it. Now, how does it practically manage? We actually looked at donor and patient telomere length in aplastic anemia transplants that we've already done. And we actually saw that patients who had good telomere length in the donors actually did well as compared to short telomere length. So this meant that we could actually then strategize for patients with shorter telomere length, what new strategies we need to do to try and improve the outcomes of these patients. The last bit is in artificial intelligence. Now, this is something which is much more new in hematology as compared to medical oncology or other specialties. One of the things people are looking at, we do bone marrows a lot. We have to sit looking down slides to see whether they are abnormal cells or normal cells. So now they are trying to see whether they can actually teach the machines to recognize abnormal from normal. So there are various systems. This is one of the what is called as the MorphoGo system, where they actually prepare bone marrow smears. They have been taught to identify each cell, whether it's abnormal, normal, and then using deep learning based system, they will actually classify. Now, only the ones which are flagged off as abnormal will need to be seen by a pathologist to confirm. And there are multiple systems like this, one which is called the Cellevision, which again is same. There are now newer systems where you just take the blood, they will actually, you have a slide maker. So you don't even have to make the slides. You just take the bottle of marrow, put it in, it will prepare the slide, it will stain the slide, it will read the slide, give you a plot and tell you whether it's abnormal or normal. Now, pathologists will go out of work, but that is somewhere down the line. We'll see what happens. Now, other than pathology, same thing happens even for karyotyping. So when we are doing karyotyping for every patient, we have to look at least 20 metaphases. You study about 50 cells. It's a lot of laborious work. So people are now looking to see whether they can be automated to see whether that will improve. Machine learning has been used a lot in hematology, especially in the flow cytometry area, to try and see whether using patterns of flow in terms of what antigen is expressed, what is underexpressed, to see whether that will help in predicting which is normal and abnormal. And so there are studies to look at minimal residual disease based upon flow patterns using machine learning, both in leukemia and acute myeloid leukemia, and also to try and distinguish between different types. So if you look at the mature B cell neoplasms, there is marginal zone, there is CLL, there is LPL. So they're looking to see whether there are different patterns which can actually try and identify each of them. One of our young doctors in the lab is basically looking at ALL and using this. So this is machine-based learning, which was actually generated out of our lab, looking at T-cell ALL to look at MRD and see the flow patterns and then see whether you can actually identify. And so if you look right at the bottom, using machine learning algorithm, they're actually able to delineate better those who are MRD positive versus negative as compared to the standard flow cytometry that we are using originally. Even in terms of bone marrow failure, people are using machine-based learning to actually find out and make models on predicting who are likely to be inherited bone marrow failure versus immune bone marrow failure. So I'll stop by saying TPO agonists are the drug of choice in chronic ITP at present, while a number of newer drugs are in the offing. Sequencing along with flow cytometry advancements have helped improve on the diagnostics in hematology. The ability to diagnose, prognosticate, and follow up with measurable residual disease have greatly helped in improving outcomes. And machine learning is being increasingly used to aid diagnosis in hematology, but needs much more refinement. I'll stop. Thank you for your attention. I'll be happy to take questions.
Thank you. Thank you. Thank you, Dr. Biju. Wonderful talk. So any questions? Okay. What is the current recommended second-line therapy for ITP after steroids, and how long do we wait to see response to steroids?
So the second line therapy for ITP right now is that you could use any of those, rituximab or TPO agonists. If you're using rituximab, you have to wait for at least 6 to 8 weeks. Generally, with eltrombopag, you would see a response in 15 to 30 days. But to say failure, you have to wait for at least 3 months.
Current treatment for megaloblastic anemia?
Same old vitamin B12, that has not changed, both
Yeah.
intravenous or oral. If you have somebody who's got intrinsic factor antibodies or who's got malabsorption, you would use IMB12.
AI has not changed that yet.
Old is gold.
Okay. Are there any more? I think that's it. Yeah. Thank you. Thank you, Dr. Biju.
Thank you, sir.
We now have a critical appraisal by Dr. Nivid.